Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me today. I'm delighted to bring you this special coast-to-coast conversation about the future of motion-preserving spine surgery in the U.S. Today, we're talking about artificial disc replacement surgery, what it is, why it matters, and why it isn't yet standard of practice in the U.S. Before we get into the details, I'd like to introduce our guests. First, we have Dr. Todd Lanman, who represents the West Coast in this conversation from Beverly Hills Spine Surgery. Dr. Lanman has performed thousands of disc replacements over 30 plus years and brings a unique perspective as someone who's had 5 disc replacements himself. Dr. Ehsan Jazini is representing the East Coast as a leading spine surgeon practicing at VSI in Virginia. He has performed many of the region's firsts when it comes to motion-preserving procedures. Welcome to you both, and I'd also like to invite you both to talk a little bit about yourselves and your practice. Let's start with Dr. Lanman.
Well, thank you for having me. It's a pleasure to be here. So yeah, I'm a neurosurgeon and I've been practicing in Cedars-Sinai Medical Center primarily in Los Angeles, and I'm associate professor at UCLA as well. And I have been, over 30 years now, but I was involved initially, and I have a spine dedicated motion preservation practice. So I was involved in the initial clinical trials studying the artificial discs starting in 2001. And I've been involved in the cervical. We have 9 discs FDA approved, and I've been involved in 6 of those trials, either as principal investigator or sub-investigator, and then in the lumbar trials, all 3 discs at some capacity as well. So I've been pretty familiar with these implants. I will implant between 10 and 30 a week with multi-level in certain patients, not that many patients, but that many artificial discs. So, because people seek out motion-preserving surgery, no one wants a fusion, and I don't blame them. And that's a whole interesting topic we'll talk about historically as well.
Great. And Dr. Jazini?
Yeah, so I'm an orthopedic spine surgeon. I trained at Maryland, Baltimore, shock trauma. So I got a lot of training, really getting the nitty-gritty of how to take care of someone in polytrauma. And then I did a joint neurosurgery orthopedic fellowship in Leatherman Spine Center. And then I moved over to academia in Georgetown before I came to private practice at Virginia Spine Institute. What's unique about our practice and what I do is that we're under an umbrella where it's truly a multidisciplinary spine unit, working with physiatrists, with elite physical therapists, and we really have the whole gamut, right? From physical therapy to regenerative treatments and motion preservation and cutting edge technologies that has always been sort of the mainstay of this practice from its foundation from Dr. Schuler's time. And everything we do is how do we get our patients back better? And so this discussion about disc replacement is really much in line with what I'm interested in, because again, it's part of how do you get your patients back to life, to their routine, and how do we do that in the best way, right? There's really been a delayed adoption of these principles within spine as compared to some of the other fields in orthopedics.
I think it's important for people to understand historically, the orthopedic surgeons have really led the way in motion preservation, starting with hip and total knee replacement. And I do a lecture where I have slides up and I put up Robert Charnley, who invented the total hip in 1958. Before that, they fused your hip if you had an arthritic hip, and they fused your knee. And people, if you were told you needed a fused hip or knee today, you'd say, you're out of your mind. Like, why would I do that? And even if you need a revision of your total hip, you revise it to another total hip. You don't revise to fusion. So when Charnley invents this total hip, all the famous hip surgeons at the time said he was crazy, this won't work, that's a fad. Well, the most successful surgery done in the world today is total hip replacement, 99% satisfaction. So they're all wrong. And the same thing happens today in the artificial disc world, where we had some issues with the first lumbar artificial disc, and that sort of poo-pooed the market, and then everybody said, well, these implants don't work. And no one's really bothered ever since. Yet we have over 836 published articles on lumbar and thousands on cervical, all showing statistical superiority or at least equivalency in pain scores and definite improvement in motion preservation. So artificial disc will become the standard, I think, over time, particularly in the cervical spine with 9 discs FDA approved. I think six on the market, probably coming down to 5, and a new one coming out probably in the first quarter, which we'll talk about later. But I think it'll get FDA approved by February. But so motion preservation and fixing disc-related back pain primarily is the role of an artificial disc. And so I'm a huge advocate. Obviously, I have them myself. I've had 11 spine surgeries, so that's been a lot of fun. 4 on my neck and 7 in my back. So I have combinations of fusions and artificial discs here and in my lumbar. I have no more back pain, but I have just good motion primarily. So
that's great. I think that for our audience members who need a little bit of background information, let's hear from Dr. Lanman on what is a spinal disc, what's the difference between cervical and lumbar, what problems happen to the disc to maybe need a surgical intervention like a disc replacement surgery?
Right. So the discs are between your vertebrae and your neck. So in your cervical spine, you have 7 vertebrae, but you have 5 discs. And in your low back, you have 5 vertebrae and 5 discs. And each disc provides a cushion between the 2 bony vertebrae that allows you to roll around. Now, when we did the initial trials, we said, okay, herniated disc, pinched nerve, neck pain, arm pain, for example. Cervical is just neck, lumbar is low back, and same in the lumbar. And so when we would do more of the younger patient population, in the lumbar, we did ages 18 to 60, and the cervical, we did older, but that was probably a mistake. We should have done to age 65 on the lumbar. Because you'll run into insurance barriers there. Like when you hit age 61, oh, that's not FDA approved for a 61-year-old, which is nonsense. Because the FDA clearly states once they've approved a device, it's okay. So an artificial disc replaces the diseased disc, whether that's a tear and a herniation or degeneration. Now, as time has gone on, the more degenerative the disc, people say, oh boy, you can't really put an artificial disc in that. It's totally degenerated bone on bone. Well, I was bone on bone, and I have 3 artificial discs where I was bone on bone in my low back. Well, it doesn't make sense to me. If you can open the space up, clean out what's left of the disc, and put a bone graft in there to fuse the vertebrae together so they never move again, why can't you open it up, clean it up, and put an artificial disc in that allows you to move? Like this is an artificial disc in the low back. You put it, clear acrylic is the bone. You put the implant in and it'll let you move. Now, why wouldn't you want that? Unless you like being stiff, or you just sit around and watch TV and play cards and drink, I guess. But I mean, most people don't want to live that way anymore. And they want to age and hike and have fun.
Right.
So disc replacements replace the discs, right? And so in the cervical 1 or 2 level were the clinical trials, and those are FDA approved. And same in the lumbar, 1 or 2 lumbar discs are FDA approved. Doesn't mean we can't do more. I often do 3 and 4 level. I'm a 5 level. I just did a 5 level on a guy, and I did a 4 level yesterday. So, I mean, you can do more. It's not against the law. Insurances, though, we can get into that if you'd like. They want to prove that, but that's another story.
Right. We'll get to that. Dr. Jazini, can you tell us, maybe just your philosophy on differences between fusion and disc replacement?
To answer the question, first we have to answer what is a spinal fusion, right? In spinal fusion, what you're doing is you're removing that damaged disc to permanently eliminate the motion at that level. Well, this can be effective for certain things, right? When you need stability in your spine, let's say the person has developed a fracture, or there's so much arthritis in those facet joints, those hinges in the back, that either it doesn't move, we can't get it to move, or the facet joints themselves are unstable. Now we can get to some more advanced techniques now that you can even address that with motion preserving technology. But that's really what a spinal fusion is. But the big drawback of that is, well, these motion segments that we just talked about, right? they're not in isolation. They work in together. And so what you do at one motion segment, when you have five of them in the lower spine, you take away that one motion segment. Well, guess what? The other four have to make up for that. It's like imagine if you're driving a car and all of a sudden now you say you have to drive on three tires versus four. Well, the other three tires are going to wear out faster. So that's the best analogy I can give to our patients and the audience that there's a huge downside of fusion, not just at that level that you just took the motion away from, but to the adjacent levels. And the data on this is very well established that the more levels that we have to fuse in someone, right, the more breakdown the other levels get, and the faster that becomes and happens, right? We all age as we get older, all our discs wear out at different rates based on our genetics, based on our activities, right? And so we don't want to do something to address one problem but create another. And that's very intuitive to patients. That's one of the main reasons patients really inherently understand it and seek out expert like ourselves, right? They come to a VSI, they go to Cedars-Sinai with Todd because they're looking for that option that inherently makes a lot of sense. With disc replacement surgery, by contrast, you remove that damaged disc, you have to restore the motion, you allow for the spine to obtain its natural spine biomechanics and load sharing. The spine is meant to move just like your hip is meant to move. If you fuse one hip, well, guess what? You're going to create stress transfer to your other hip, your SI joint. And so that's very inherently understood. But for a lot of reasons that we can get into in the next sort of phase of this talk, that hasn't taken off in the US.
Well, thank you both for that clear explanation. Now, let's go back in time. Dr. Lanman, you were an early adopter of disc replacement, I believe going back to 2001. Tell us what things were like back then.
Well, then we were running the clinical trials, so there was no approval. The first approval comes in 2005 of the lumbar. It's that one. And the cervical actually came later in 2007. Cervical's much more easily adopted by insurance approvals than the lumbar was. Like I mentioned, the first disc was called a Charité. It was a little bit hypermobile and allowed too much motion. And so the results weren't great in that first lumbar disc. And like I mentioned earlier, that sort of skewed everybody's opinion. Well, these discs don't work and so forth. Well, if you think about a total hip, I mean, how many revisions of total hip versions are there? I mean, it's hundreds of different versions of total hips now versus the originals. They've all been generationally changing as technology improves and so forth. So the newer lumbar discs are phenomenal and they do great, but everybody's just stuck back in time, like you said, and they're like, well, these discs don't work. And so you'll go to the big university centers and they're just fusing everybody. And it's such a disservice because when the fusion patient comes in to see me, they'll tell you, oh, my back pain is better. Well, this is after everything heals in 3 to 6 months. And they'll say, my back pain is better. I feel better. But when you do an artificial disc patient, they'll come in 4 to 6 weeks and they're like, I feel amazing. Like I feel great. And that's a subjective difference. It's not quantified, but the data is really clear that there is superiority. I think if you were talking about lumbar, because it was really the studies were on the bottom 3 discs. I do all 5 discs. I do a lumbar. I have a lumbar 1-2 disc replacement, lumbar 2-3 at the top, which are tricky. Those were never studied because we didn't have excess surgeons to get us there. So we use a vascular surgeon for the approach to get us to the spine. And it's tricky getting high. So the study was done on the bottom 3 discs, and it was for 1 or 2 level. And all of those show, and L5S1, the very bottom one, because it has certain angles to it, even though it's the easiest disc to get to, it's the trickiest one to get the best result with because there's a lot of angular configurations biomechanically there. So if you subtract out L5S1 on most of the studies and just look at the L3, 4, 4, 5, the 2 middle discs, lower and middle, the superior outcomes of all those implants. And so L5S1 is just a little harder, but nonetheless, And the cervical data is unequivocally clear with statistical superior, because all you have to show the FDA if you want to get your device approved is you're as good as the standard. Well, the standard was fusion, so we had to randomize to fusion. So you just have to show that you're just as good. Well, the data came out and we're like, well, hey, wait, it's way better. And then we followed out, and then the FDA is like, well, let's wait. So then they extended it to 5-year follow-up from 2. So we're like, okay, we're at 5. It's still great. Then they're like, okay, well, now let's wait till 10. So they keep extending the trial, because they're not believing the data and whatever. So at 10 years, statistical superiority. So, and they kept improving. And then, as Dr. Jazini mentioned, when you have so we had looked at the 2 groups. You have 2 fusions in the neck and you have 2 artificial discs in the neck that move, and these fusions don't move. So these are locked. These are moving. The disc above or below the fusion has a 2.9 times greater chance of needing surgery at 10 years. Well, that's huge. I mean, nobody wants to go back. I mean, I've had, 3 here and 1, but, that's no fun. So, yeah, disc replacement historically back in the day was tricky. And then getting the insurance companies back then, it was hard for them to approve it. They sort of started approving it right away. Then they pulled back. And it's been this whole struggle. They're approving most implants now in the cervical. That's pretty much easy to get approved for 1 or 2 level. Sometimes you can get a 3 or 4 level approved. That's hard. If I'm doing a 3 or 4 level, the patients just buy the discs and we put them in. It's just the way it goes. So, you can do whatever you want. And the FDA says clearly if the device is FDA approved and the doctor wants to use it at 3 or 4 discs, that's fine. We can't do a clinical trial at 3 or 4 discs to study it because nobody's going to sign up for a 4-level fusion in their neck or their back. No one. So you would not be able to do the trial. So anyway, the FDA says it's fine. We say the device is safe and effective. The physician can use it in what's called an off-label manner at multiple levels. So what? Okay, so we do multiple levels and the patient buys the implant and I put it in. That's how I do it. But so we have big studies. Matt Gornett published a 3 and 4 level cervical trial back then. I have one that I'll be publishing soon as well. And it's superior outcomes. I mean, they're all fantastic. So there's no reason for anybody to get fused anymore, in my opinion. And I think that'll be the standard someday. I know. Yeah.
And the other issue is that is not the standard, has to do with training, right? There still is a huge training gap with surgeons who are coming out because at those academic, more conservative institutions, they're really slow to innovate, right? And so if you were not exposed to it as a surgeon, well, it's not bad intent. You're just going to come out and say, well, I don't know that technique. I'm not sure what the results are. What I hear from patients is, yeah, the surgeon said that's probably a good idea, but we don't know what's going to happen in 5 years, what's going to happen in 10 years, what's going to happen in 20 years. But now we have those studies. The studies are very clear. I mean, there's like 30-year data now out of Europe showing the incredible longevity of these disc replacement devices with very low revision rates, like at 1%. And so as long as we keep doing the same thing over and over again, nothing's going to change. And so you need people and practices like ourselves who are going to be on that cutting edge to keep pushing the field forward. Otherwise, the more established conservative institutions, what people think as these big academic powerhouses, won't do that because of a lot of these reasons that we should discuss: insurance, lack of experience, and really a cultural resistance to change.
I often see patients who have gone to the big universities, and I tell them, hey, the chairman of that department has published a lot of papers. Doesn't mean he's a great surgeon and doesn't mean he's really thinking out of the box and trying to, like you said, really promote something new and something more innovative. And so that's a real hindrance. Our fellows, we have 3 spine fellows a year that train it with us. And if they're from the East Coast, it's like awesome because none of them have done a disc. None of them have ever. All 3 right now, our 3 fellows today. I asked them all, how many artificial discs have you done? One of them said 1 cervical in his whole residency training. 1. I can, that's, so and I go, how many lumbar? And they have zero. They've done none. So it's insane. Like they're not getting trained, like you said. So because these guys don't
Yeah.
do them. And so they have to
Yeah.
come to our fellowship. There are really, a couple primary centers that are doing large amounts of these and have training centers. So we're one of them at
Yeah. So yeah, I
CSI.
mean that's you do definitely touch upon a big, general difference between West Coast, East Coast mentality. Tom Schuler, our founding physician surgeon here, started this practice of ESI, and his fellowship was on the West Coast. So he brought that type of mindset to VSI, and that's why VSI, from its founding, has always been very focused on motion preservation, on cutting edge technologies, on things that are even non-surgical, like regenerative treatments to really help advance that. And a lot of that difference in philosophy has to do with this difference overall into some of these big institutions, especially the East Coast. Think of the Ivy Leagues versus West Coast. And so, what's great for me as a younger surgeon, gaining more and more experience in disc replacement and really doing a lot now in it has been this transformation, but also being part of a practice that has given me the space to push the envelope and to keep innovating for our patients and being able to do 2, 3, 4 level replacements when it's the appropriate for the patient.
Yeah, it's
Dr.
important.
Jazini, in your practice, Dr. Lanman talked about the FDA approvals and insurance, struggles and how he gets around that. How do you see, the FDA approval and the interpretation of that by the insurance being a problem in your practice?
It's definitely it continues to be a challenge. I definitely have seen more and more of these being approved by insurance companies. It does take more time and effort by our team, by myself. Oftentimes, I have to get onto these something called peer-to-peer conversations with the medical director of whoever's in charge of that specific insurance company. I would say for the most part, when you have a face-to-face conversation or on the phone conversation with another physician, and you really truly lay out your reasoning and logic, most of the times I would say they actually do end up approving what we want to do because it inherently makes sense. If they would themselves needed that surgery with those set of circumstances, they know that's the appropriate thing, right? No one's going to be like, yeah, fuse my hip. So when you have a conversation, um, usually you can get this approved. You have to go out to bat for patients. Sometimes patients do have to, unfortunately, burst some of that cost, right? Because insurance companies are always going to go behind the umbrella of this is not FDA approved or this is not within the FDA guidelines because the more than 2 levels have not been studied, right? And a lot of that has to do with financial incentives that they've placed, barriers that they have placed. But when there's a will, there's a way. When the patients are seeking it and you are pushing for them, I think the two together usually leads to a very good outcome. When I first started doing this, I was looking for that perfect patient to do the replacement on the youngest, softest disc where, everything from a textbook standpoint, okay, this is a great candidate for replacement. But the more I've done these surgeries, I've realized that there's been a paradigm shift. Now I'm basically asking the question, why should this be fused? Because you have to give me a good reason why each individual level needs to be fused. And if that's not there, then we will do a replacement for each level, right? So you really have to customize it to the individual patient, but also to the individual level to get the best outcome.
That's great. And for surgeons who initially were excited about this technology, but ran into all of those insurance struggles and kind of gave up on it, is there good news that you can tell them on how things have changed and how insurance, is approving things these days, even though maybe not everything? Is it better now?
Well, things have improved with approvals, but still, but what I often do is every state has an insurance commissioner and have the patient file a complaint to the insurance commissioner. We'll give them all the articles and they could submit all this with 800 articles for lumbar disc replacement. And it's hard for the insurance commissioner can override any insurance company and force them. But we do that a lot. So that's one little trick you can do. The other trick is if you work for a big company, you go to your employer and say, why aren't they approving my disc replacement? So they call up Blue Cross or whoever it is, And if they have 10,000 employees or 1,000 employees, then the medical director of the business is or the HR of the business is calling the medical director and says, well, why aren't you approving an FDA approved procedure on my employee? That has huge impact because they don't want you pulling they don't, you pull 1,000 patients off and put them somewhere else. That's a huge financial impact to them. That's another method. So there's ways to really have the patient has to be the advocate for themselves because there's only so much Dr. Jazini and I can do, and how much time can we spend on a phone call with some doctor we're trying to convince who's 95 years old and is a pediatrician and doesn't know anything about spine, and he just goes down the list and doesn't approve it a lot, and so but it's getting easier certainly, but it's worth fighting the battle.
And Dr. Jazini, do you find that patients are still needing to explore options in Europe because of the issues here in the United States, or are you finding that you're able to kind of take care of people here?
I think we've definitely closed that gap a lot. I think early on in my career, there's still a lot more patients traveling to Europe. As some of these elite centers like ourselves, VSI, there's obviously TBI in Texas and Cedars-Sinai, um, have really become elite centers, and we have a lot of data, and we have like in our practice, a multidisciplinary practice where we've taken care of a lot of these patients. The hospital team is really aware of what we're doing. Our physical therapists are all in sync to figure out both the pre-op, the intra-op sort of hospital stay, and also the post-op care. More and more patients are traveling within the US to come to see us rather than going to Europe because they don't want to go across the ocean. They understand, obviously, there's no language barrier, there's no insurance barrier. And as we were getting more insurances to help cover the costs, it doesn't make sense for patients to travel to Europe. I think Europe has done us a favor by pushing that frontier and helping innovate and getting us that technology. But at this point in time, I don't really see a reason why someone really needs to travel. I think it's really important that they pick a surgeon that does a lot of these. There's a support system around them. Like it's really hard to do disc replacement just by yourself with no support and no experience, right? And I'm not sure I would really recommend that. It's like hip and knee replacements too. You really want to go to a hip guy or joint guy who does a lot of hips, has a system, has a team, right? And a philosophy of care. Otherwise, if they're just doing one a month, then they don't have a system, and that's when you get into trouble.
Yeah. Well, let's shift gears a little bit. Dr. Lanman, people love to hear when surgeons have their own personal experience to share. Can you tell us maybe some similarities or differences that you've noticed between your fusion surgeries and your artificial disc replacement surgeries?
Well, so my lumbar, I have the two lumbar are fused at L4551. I had an artificial disc at L5S1, which is I kind of screwed that up myself. It's a long story. So that's now fused. Unfortunately, the only place I ever ache is where my fusion is on the bottom two. The first surgery I had were the top three, L1, 2, 2, 3, 3, 4. And those are three artificial discs. And I've never had any pain up there ever since. Zero. So the difference is I get achy, like in my low back where I have metal and screws where the fusion is. It's not bad, but it's a 2-3. It's background noise though. I don't feel amazing. I did until I blew up the 5-1, which is something I crushed onto the bone by overdoing it too early, which of course I didn't follow my own directions. So the interesting thing about L5S1, I think this is important, and then I want to address the Europe thing, is L5S1 turns out, and I've been measuring this along with Terry Marnet in France, who invented ProDisc, and there's a measurement called RACE, which if you measure from the sacrum to lumbar 1 on flexion extension, that arc is RACE. And you lose about 25, 30 degrees by fusing L5S1. We used to think it didn't matter to fuse L5S1 that much. Well, it really does. And ever since my L5S1 is fused, I can't do a full sit-up. And before I can get just about there. But then I stop. So starting with artificial discs is, I believe, always the way to go. It can always be converted to fusion, but if you start with the fusion, it's really tough to convert that to a disc. I mean, it's very hard. Now, Europe, I agree with Dr. Jazini. Patients don't want to travel there, and there's no reason to. And I literally have several patients that have gone to Germany, and I'm like, and they just went a few years ago. I'm like, what why? Like, what are you doing? I'm right here in LA. Like, you're like 5 miles away. So they're realizing now that they don't need to do that. The other issue is the viscoelastic core implants, which are polycarbonate urethane. We're seeing that's ESP in Europe. It's not approved here. People are kind of seeking out. There was M6 here, which the company took off the market. It has a soft core, which intuitively sounds good. But if you look at the data sets between the hardcore implant, like a hip, like a knee, like a Pro disc or an Activell lumbar disc with ultra high molecular polyethylene, and then you look at a polycarbonate urethane, a soft core viscoelastic, because it sounds like the disc that does this acts like more like a human disc, that the data would be better. It's not. It's the same. The only problem is the soft discs, you know what happens to them? They wear out. Any implant that moves will wear. Last thing is getting kind of deep into it, but there should not be a mismatch between the modulus of elasticity between the core and the end plates that you're inserting in the implant. So I have a few concerns about the simplified disc because the end plates are PEEK, which is polyethyl ether ketone. It's a softer plastic, but the core is ceramic, which is hard as a brick, like marble. And so we've had some drilling where the core drills a hole right through the PEEK. So we have an article that it'll be coming out soon. It'll be published shortly on that. So I'm concerned about mismatches. I think right now on the technology side, as far as advances, right now we're going to stick with titanium and ultra high molecular polyethylene, just like the hip and knee guys, because they last, they don't fail. You know, it's rare the implant fails, by the way. It's not, people are like, well, my disc didn't work. Well, when I look at their films, like, well, it wasn't put in right, or it's the wrong implant for you that they put in. So there are 9 discs FDA approved in the neck, right? 6 on the market. It's like, well, which one's the right one for you? Because they all do something a little different. And that's really important that the surgeon understands the biomechanics of each disc, how they move, which one's better for someone with a steep slope in the cervical spine, a steep slope in the lumbar spine, because there's more shear force on the implant versus the flatter neck, the straight neck. Anyway, this is a lot. And experience centers, it's important, like BSI and us. And the I just did a 3-level that was, I revised. He had a 3-level MobiC, hypermobile disc on a guy with hyperelasticity of his ligaments. Well, that's a fail because it's too loosey-goosey. And so he was all over the place. You could see the implant doing this and this. So I switched him to a much more constrained fixed core device, and he's doing fine.
And you can't be like a one-trick pony, right? You have to
That
really understand all the tools and understand what's the trade-offs, what does the patient need, what's the patient's motion, what's their physiologic motion. That means how much do their discs move at the levels that are normal, what's their alignment, so that you can pick the right implant. Sometimes we'll do a different implant for different levels within the same patient as well, right? So you really want someone who is really well versed with the technology, understands the biomechanics, so then you can deliver for your patient the best thing, right? I 100% agree with Todd. Like, we thought maybe L5S1, okay, if you have to fuse that, it's not a big deal, and you can just do a replacement at the levels above. But sometimes I actually do the other way around. The L45 is super unstable, but I can still replace 5.1, and I can see I see a tremendous benefit for the patient by preserving that motion, even above a multi-level fusion, because of, let's say, they have a really bad scoliosis. And so as we do more, we understand this technology more, it intuitively makes sense, but a lot of times these things sounds like, wow, this is so cutting edge, but really we're just so far behind relative to other fields of orthopedics. I remember I did a mission trip in Bhutan, which is like in the Himalayas near Nepal, And that was the first time I actually saw a patient who had a fused hip because in that country, they don't have the technology, they don't have the system facilities to do a hip replacement.
Yeah.
And so in this country, it would be like malpractice if you fuse someone's hip, right? And so I'm not suggesting that that's the case with spine, but I think patients will keep demanding and drive this adoption, and there will be eventually an inflection point when it becomes a core skill that you have to know in training. Right now, it's still a niche. You still are really is driven by the early adopters, and until we get to that inflection point, which is really being driven now by the public, we won't see that really become mainstream.
Right. There will be an inflection point, and it'll be driven by the patients, which I'm seeing. I mean, my patients fly in from all around, especially the East Coast. Like that's all they do is fuse everybody out there. It's hilarious. Like, it's the biggest patient feeder for me that there is the East Coast. I don't know why. I don't know
Well,
why.
the current technology is really exciting, but sounds like there's many different implants for many different types of pathologies. You just have to have the right surgeon who knows when to apply the right tool to the right patient. But what do you both see in the future, maybe the next 10 years? Where is this going?
Yeah, I think there's two pathways. One is biologics. I think we are getting more and more good data on some of the regenerative work that we're doing for patients with early disc pathology that is they're not quite ready for a disc replacement surgery. It's not that bad, right? It's not like causing constant pain. They're getting these bad flare-ups twice a year, three, four times a year. They've done really good therapy, and we can help those patients, right? And I think as that data and that technology gets better, where we can really preempt some of the degeneration that's happening within the disc, that's going to be a huge part of the future of what I see in terms of motion preservation. Is actually beyond just surgery. But in terms of disc replacement surgery itself, I think the implant technology, the surface technology, how to get the implant to even better match the size of the patient so that you can expand the cohort of patients that it can be available to. Because a lot of times the main problem, especially with the low back, the lumbar disc replacement, is good bone stock, is how strong your bone is. And so if we can get a bigger coverage or footprint, it shares that load across the vertebral body. And so it's going to enable us to offer this surgery to a bigger number of patients. Also creating replacement devices that can be placed from different approaches, let's say from the side versus from the front, that sometimes we can't get to because of the vasculature. Sometimes the upper disc, you can't get to it because of the kidneys, right? So enabling technologies that will allow us to place the implant from different approaches and make it even less invasive, I think is a huge part of the future.
Great.
Yeah, I agree. I think some image guidance for the lesser skilled surgeon will be helpful on centering, and people don't really, if you do a fusion, I've said this before, it's like, a monkey can bolt a plate on the spine. It's like not that hard. It doesn't have to be perfectly lined up. You just need the screws to be held into the bone in the right spot. And they'll heal up and their nerve pain should settle down because things aren't pinned. But you do an artificial disc, it's a lot more skill involved, right? You need to do a proper decompression of all the nerves because this implant will move. And if it moves, it'll pinch nerves if the nerves aren't totally freed up. And then it has to be centered and it has to be perfectly placed. And it can be off a couple millimeters in certain directions, but in general, it needs to be well centered. And so sometimes we'll see implants coming in and they're way off to the side, and we'll revise those and I'll move. And when I do a revision, as I mentioned earlier, I'll revise disc to disc. So I'll explant, revise. I've asked the companies, they need to make taller discs. Like Protus makes a 7, Prestige makes an 8, which is my Medtronic. But we kind of need 8s and 9s because if you explant a 6 millimeter and you shave a little bone, you need more room to taller implant to put a new disc in. Otherwise, you end up with the fusion, which isn't wrong, but it's more limiting, certainly as I've found out. But I think things are shifting. I think image guidance will help with implantation and a proper position. And I think some of the biologic work that's being done in degenerative disc is somewhat promising. Nothing cures aging. So I'm finding out. It's weird. Um, Nothing's getting better as I get older. Now when I go to bed, it's if the pillow's like a millimeter off, I wake up like I'm auditioning for a zombie movie. I can't turn my head, things like that. But it's funny. It's being proactive. Last thing I'll say that I think is important, and I would recommend our audience to really think hard about this. If you need a total knee replacement or a total hip replacement, okay, wait as long as you can. But if you have back pain, get an opinion from one of us more experienced artificial early. Most people I see, I don't recommend surgery to. Same with Dr. Jazini. But here's what we want to find out. Do you have disc generated back pain? Are you a candidate for an artificial disc? Because if your doctor said, wait till you're crawling in to see the spine surgeon, okay, now the disc has totally failed. The joints are all arthritic and failed. And now we're left with very little in our armamentarium other than fusion. So if you're early, then we can offer the artificial disc, replace a diseased disc. The diseased disc usually, not always, but usually precedes facet disease, arthritic joints. And so if you can replace the disc, you actually offload, we've measured this, and you'll offload pressure on the facet joints and restore and give you a lot of time. So I
I
mean,
agree a lot. I think early is better because a lot of times it could be, their hip mechanics are off. They have pelvic obliquity. That means that one leg is shorter than the other. There's other things that we can help the patient. It doesn't necessarily mean they need surgery, but there may be things that we can then help the patient sort of avoid further degeneration with proper hip mechanics, working on their core. I mean, you shouldn't just see a spine specialist just because you want surgery. In fact, more than 90% of our patients don't ever require surgery. And so early is better because if your bone density, let's say, is not great, then you'll have more time to help beef that up. There's now really good medications that can help reverse that. Where a lot of times, I just had a younger guy who had a hormone deficiency, and so we got his testosterone fixed, and then his bone density got better, and then he all of a sudden became a good candidate for a disc replacement surgery. So coming and seeing someone early is actually much better because then we can potentially preempt problems, but also help get the patient to a better place in their life. And even if they do need replacement, it increases their chance to get a disc replacement or a motion preserving technology instead of a fusion surgery.
right.
That's great. Yeah, I think that one of the sort of bigger picture items is that, activity and maintaining activity levels is really great for your overall health. I mean, inactivity really affects your cardiovascular system, the development of diabetes, all these things that then lead to poor quality of life. And so it can be a domino effect. And if you wait too long and that's where you're stuck, there may be no point of return. And so I think that this also helps the global health of the patient.
Correct. And like I'm wearing my golf shirt because I'm going to go golf after this. I'm not very good, but I'm going to give it a go.
Yeah.
Exactly.
With
Yeah,
all
I
these
think
11 spine surgeries, I'm still golfing, is my point, right?
Yeah, that's amazing.
years from now, we'll, look back and wonder why, we were taking motion away from so many patients and it's going to become a default. So it'd be interesting to sort of rewatch this episode like in 10 years from now or 15 years from now, because I think the inflection point is near. I don't think it's there yet, but at least from what I'm seeing in terms of patient education, I think a lot of these AI chatbots have really empowered patients to be able to really see the data for themselves and to go armed well with data. And so they're seeking more and more the proper treatment, right? Versus before they would get lost in the weeds, right? They didn't know where to go and they would just go to their nearest surgeon or nearest center, or they would go to these big academic institutions. And so I feel like that inflection point, as the patients are getting more informed and empowered, I think that inflection point is very near.
Yeah, I would agree.
Thank you both for sharing your insights. Artificial disc technology is more than a procedure. It's part of a larger shift towards motion preservation, improved outcomes, and patient-centered spinal care. Thank you.
Thank you.
Thanks for having us, Lindsay.